We are going to start. We are going to start immediately now. My name is Oluwatoyin. I am the chairperson of the Operating Room Global Workplace Health and Safety. I am happy to welcome everybody from different countries, from Nigeria, from Ghana, Pakistan, from USA, Ethiopia. I appreciate you all for being here. So today we are going to start, and the topic we are discussing is reducing musculoskeletal injuries in healthcare ergonomic solutions and best practice. Our speaker is going to be Oluwatoyin Akinlade, but before she starts, I'm going to read her citation. Can I be heard? Can I be heard?
Yes, you can be heard.
Yes, you can be heard.
Okay.
Yes.
Oluwatoyin Abiola Akinlade is a dedicated nursing professional with extensive experience in education, clinical practice, and leadership within healthcare sector. Currently serving as a nursing faculty at Adams State University in Alamosa, Colorado. She's committed to shaping the next generation of nurses through innovative teaching methods and comprehensive clinical supervision. Prior to her current role, Oluwatoyin was the operating room manager and educator at San Luis Valley Regional Medical Center, where she oversaw nursing staff, coordinated patient care, and provided essential training to ensure high-quality surgical outcomes. Her previous experience includes working in Lagos State University Teaching Hospital as a perioperative nurse, as well as serving as a young midwife leader with ICM. She is currently working to obtain her Doctor of Nursing practice in population health from Colorado State University and a Master's in Nursing with an emphasis in education from Grand Canyon University. Her foundational education includes a Bachelor of Science in Nursing, an associate degree in midwifery, an associate degree in nursing, all learned in Nigeria, all earned in Nigeria. She is a member of the Operating Room Global Education and Training Committee. As a certified nurse educator and CNOR, Oluwatoyin is passionate about advancing nursing education and improving patient care through evidence-based practices. She continues to contribute to the nursing field with her extensive knowledge, leadership abilities, and dedication to fostering a culture of excellence in healthcare delivery. Can you please help me to welcome Oluwatoyin Akinlade, our presenter for today? You are welcome, ma. Kindly have the floor. Thank you very much.
Thank you so much.
You are welcome, ma. We really welcome you.
Thank you so much. I appreciate you. Thank you so much. My name is Oluwatoyin, and it's a great pleasure to be here as the presenter for this webinar series. I would try to share my screen. Give me 1 second. I'm trying to share it now. Can we all see my screen?
Yes, yes.
Perfect.
Yes.
All right. Thank you, everybody. My name is Oluwatoyin once again, and this morning we'll be discussing ways to reduce musculoskeletal injuries in healthcare, ergonomic solution, and best practices. I would send this slides to, I think I should be sending to Mommy Oluwatoyin Helen afterwards, so we can have access to it when we're done with this webinar. All right, let's start. You're welcome. Okay, so my introduction today says that musculoskeletal injuries, that's MSIs, they are injuries that affect muscles, bones, tendons, ligaments, and nerves. I'm sure we agree with me. And it's often due to repetitive motions or excessive strain, the kind of work we do as healthcare providers, as nurses, as everything that we do in the OR tends for us to go into stressing and straining ourselves. And this is when we develop all these kind of injuries. Just like I said, it's common in healthcare setting and it's due to the physical demand of patient care. We all understand this as well. Why are we discussing this today? That's the importance. Musculoskeletal injuries are prevalent among healthcare workers and it leads to significant health issues and increased costs. I'm sure we've seen someone or know someone that this work that we do as cost has him or her some kind of issues that now it's brought a lot of strain on us because now we have to look for someone to cover the shift. And at the same time, it has increased the cost of things that this person has to go through to take care of his or herself. And so many things like that, increased cost of things. The safety and well-being of healthcare workers directly influence patient care delivery. If we are not well, I don't see how we can well take care of our patient. That's why it is very essential that we as health workers take cognizance of this and make sure we're in good health so we can also help our patients and give them a good quality of care. I'll move to some statistics that I saw that I want to use in buttressing this. According to US Bureau of Labor Statistics, healthcare workers experienced over 300,000 musculoskeletal injuries in 2020. This was 5 years ago. So you can imagine what it is now. This is the recent one that they did, and it's 5 years ago. So you can imagine what it is now if this is what it was 5 years ago, accounting for 29% of all workplace injuries. Nurses report injury rate of 35% to 60% depending on their practice area. So where you practice depends, it's streamlined. The kind of injury the person will have is streamlined to kind of what they do. So I want to believe surgery area is one that is going to cause a lot of strain because we have to lift, we have to bend down to pick things, we have to carry things. So I want to believe we should be having one of the highest record. All right, common causes of MSIs in healthcare. One of them is physical demand. Just like I said just now, lifting and transferring patients without proper techniques. So many of us wants to get the job done, or so many of us believe I can do it, I can lift this person without really thinking it through, the impact it's going to have on us with time. At the moment when you're lifting this patient, you might not have any injury, you might not feel anything, but think about it. Doing that same thing over and again for patients as you go along without using proper technique, what can happen to us? Repetitive tasks such as data entry and equipment handling. I don't know if some of us or all of us use a computer in our chatting system. I want to also let you know that chatting for a long time, handling the mouse, things like that can cause some kind of injuries on our hands. So these are the things that can also happen. And equipment handling, people just pick up things. They're like, I can carry it. It's not too heavy. You carrying it over the period of time, not just at the moment you're carrying it. So whenever we're doing anything, don't just think about what I'm doing at the moment, but the effect over a long period of time is what we should be thinking about. The next point here is environmental factors. Poorly designed workplace that do not accommodate ergonomic principles. So many place of work, my own inclusive, you find out that the chairs they use in sitting is not comfortable. That's for people that are not in the OR at the moment when they're operating. Even those in the OR that has to sit when they're operating or has to chart when they're operating, the kind of chairs, the kind of tables they use, it's not proper for what they should be using, because these are the kind of things that the ripple effect of what we do that causes all these injuries. So these are the things we should look out for. Another thing is inadequate tools or equipment that require excessive force. So there are some things, say for example, I know of some equipment where you have to open them. Maybe it's an autoclave, maybe it's a sterilizer, and you have to open with all your strength, straining your hands, straining your back, and straining some other part of your body just because you want to open these things or carry these things. So these are the things that causes injuries for us as health workers. Organization factor is one other thing, and high patient to staff ratio leads to increased workload. These I agree that most of us face at our workplace. Now you have to care for 15, 16 surgeries at a time, and you have to be there. Now you have to carry the patient from their bed. That's if they're not able to do it by themselves. You have to lift from their bed to the operating room bed, or from the operating room bed back to their own bed, things like that. Doing that for 5, 6, 7 days in a week and continue to do that. You can agree with me that this is a very major factor. Insufficient training on safe practices and ergonomics. All of us just works, and sometimes it is important to remind ourselves about these safe practices and ways by which we can help ourselves so we don't get these injuries. Are we all with me? Any question?
We are with you, ma.
Okay, if you have any question, you can put it in the...
with you.
All right, you can put any question in the chat box. I'm sure people would see it, and then after we're done with this presentation, I can attend to them. All right, my next slide today will be talking about some of these ergonomics in healthcare. Ergonomics, everybody knows it means the science of designing workspace, tools, and tasks to fit the worker's needs, aiming to minimize discomfort and maximize productivity. In essence, the way surgery floor should be designed should be exactly what is going to help them and fit into what they are doing. It should not be, all workplace should not be designed the same way. So the way OB should be designed should be exactly what we help them. The way surgery should be designed should be what we help the workers. If you get what I'm saying, it should be something like that. Not that everyone has the same thing and then it's not helping the set of people doing the work to help them to be productive. Goals of ergonomics is to reduce physical strain and improve efficiency, safety, and comfort for healthcare workers. So in as much as we're trying to help our patients, in as much as we're trying to make our patient feel safe, at the same time, our safety, our comfort is also very important, because if we're not safe, if we are not comfortable, I don't see how we can well take care of our patients to make them safe and also comfortable. You can imagine someone that has a back ache or back pain, and he or she has been managing it for a while and needs to transfer a patient. Maybe say the patient is morbidly obese, for example, needs to transfer a patient from their gurney, that's their bed, to the operating room bed, for example. And then say he or she is on the side where he has to take the patient, receive the patient. So the side he has to receive the patient, he has to lift, and then he feels this strain. He can drop the patient. He or she can drop the patient. And just imagine the ripple effect that can happen to the patient themselves, the other health workers that are lifting with him or her, trying to salvage the patient so the patient does not fall. Everybody goes through that kind of issue. And then so many things can happen. They themselves can start to develop injuries too. Patients surely will develop injuries. So it's a ripple effect. We should think about all these things when we're thinking about working to get ourselves well. Also, patients must be well, we too must be well. That's what I'm saying, makes sense. All right, I have some tools here that AORN published, and I want to talk about them. The first one, the first ergonomic tool they published was lateral transfer from stretcher to and from the OR bed. We have some risk factor that can happen when we want to do this. Sometimes because we have to transfer, we are reaching excessively, trying to stretch ourselves. And you can imagine I'm trying to demonstrate. I don't know if you would understand, but trying to stretch ourselves to get a patient, reaching to the patient on the other side of the OR bed where you are, trying to make sure the patient is comfortable. You're straining our backs. So we have to find things to do to this to stop them. All right. Another thing is when we're trying to push or pull, the person that is on the side where the patient is supposed to come to the bed is trying to push, and then you are trying to pull. These are the things that create strains on our musculoskeletal system. Bending So many of us do this. We want to bend to pick something. We want to clean the trolley. We want to do so many things that requires bending. What are the ways by which we can help ourselves that even though we have to bend and do these things, but at the same time, we're helping ourselves to make sure we don't have all these injuries. Awkward position. If you've seen people that scrub, for example, they take a position and you're looking at them or you're looking at yourself that why is this person bending this way? Why is that person bending this way? These are the things we can help ourselves with. When you see someone doing that, you want to remind them good posture. When you're doing that, you want to remind yourself good posture, because you might not really feel the effect now. You might be thinking, oh, I'm still young, I might not feel the effect. But think about it, in about 10 years, 15 years, are you still going to be saying the same thing? So this is why we have to address all these things now, because we want to be in good health. Even when we're working and outside of work, we still want to be in good health. Another one is excessive load. What is the maximum weight limit that is approved, or that is evidence-based that this is weight we can carry? And when this person is more than this weight, then we need help. How do we lift this patient? What kind of help do we need? These are the things we'll talk about. All right. I talked about it here that if a patient is supposed to be supine, anesthesiologists support the head and neck. They are always at the head of the patient. So their job, one thing I want to say is when it comes to lifting, carrying, especially when the patient is involved, all the healthcare professional in the OR is involved, including the surgeon. Everybody should be involved. So it shouldn't be that I have to do it myself, except you have enough trained people in the room that can do it. And perhaps someone has to step out and do something, but everybody should be involved when we're helping this patient. Just because, one, we want the patient to be safe. At the same time, we want to distribute the weight of that patient so that everybody helps in carrying and nobody suffers the brunt. All right. When the patient's weight is greater than 157 pounds, it is advisable to use a lateral transfer device and 4 caregivers, including the anesthesiologist. That means anesthesia provider and 3 other people will help in lifting or carrying the patient in a lateral position when the patient is greater than 157 pounds. I know we use kilogram in most places, but I'm sure we can also convert that. If a patient is greater than this, then this is what we should do. And if a patient's weight is lesser than 157, if it's, sorry, the first one is lesser than 157, the second one is greater than 157. Use mechanical lift with supine sling, mechanical lateral transfer device, or air-assisted lateral transfer device. I'm not sure if most of us knows what this is, but if this is what we can evidently ask us, you have to have something to present to them. You have to have data of what has happened in the hospital and how you think it can help. Then you can now present it to them to tell them that these are the things we can buy to help our staffs. Because if you have in your hospital people coming down with back pain, leg pain, shoulder pain over the time, these are the records we can keep and then present to the management to let them know that this is a high time for us to get these kind of devices to help in transferring patients. It will not just help the workers alone, to also keep the patient safe. So if you want to do this, you have to have things to present to them if you want them to agree for us to buy these things. So for people that know them, know what I'm talking about, devices that we can use in transferring the patient to the bed. And then some of these devices we leave on the bed till we're done, and then we use in transferring the patient back. Some it's taken away, and then another means of transfer is used when the surgery is done. All right, for prone position now, anesthesiologist supports the head and neck always. And then if the weight of the patient is lesser than 73 pounds, use minimum of 2 caregivers. Recommend 4, but you can use 2, but we recommend 4 because this is a 73-pound person. And if the weight is greater than 73 pounds now, use a minimum of 3 caregivers, recommend 4, and also use a mechanical lift preferably. These are things that we can do to help ourselves, not just to minimize having musculoskeletal injuries or issues, but at the same time ensuring that even when we are keeping the patient safe, this kind of things are liable to legal problem. If you drop a patient, something happens to the patient, God forbid, after surgery, patient just had a procedure on the head, and you can imagine dropping the patient and hitting the head on the floor. It's a lot of things. So we're helping ourselves at the same time we're helping our patients. The second ergonomic tool is repositioning and repositioning the patient on the OR bed into and from supine position. So if the patient was in supine position when you had surgery, you want to put the patient back, or if you want to put the patient in supine position on the OR bed. So these are some of the risk factors, just like the other one, excessive reaching, bending, excessive load. That's if the patient is also has a BMI greater than BMI that is greater than 29. All right, location of risks on impact of tax. Things that can happen when we try to do this kind of position is we can have back issues, shoulder issues, our hands, our knees, and I'm sure we can agree with me. And then some of the things we should know is for weight limits, if a patient weighs less than 68 pounds, and then manual lifts or lowering of torso. So if you want to, I'll still talk about it during the course of this presentation, but there are ways by which we can bend to help ourselves so we're not straining our back so much, at the same time our knees, and then after we're done, we are feeling the pain. So we talk about all of this as we go along. All right, position patients into and from lateral position. Anesthesiologist again, always and always the head and neck. And then if the patient is 115 pounds, you want to use a manual position that is approved. I also used to say something. In using all these mechanical and all these lifts, make sure these are things that are approved by your institution. Some institution will say we approve this, while some will say we don't approve the same one that this institution is using. So make sure you're covered by your institution and you're using what your institution approves, so that when you have to, say for example, you have to come explain yourself why you use a particular mechanical device, you can always say, this is approved by the institution, not just saying it with your mouth or someone telling you words of mouth that this is what is approved. You want to make sure it's a written policy of things that you can use in lifting a patient or using mechanical lifts for anything, not just patient, for anything, for instruments, for equipment, things like that. All right. If the patient's weight is greater than 115 pounds, then use assistive technology. So assistive technology can mean, I know some kind of OR that have a kind of forklift in the OR. It's a kind of lift, but it's attached to the wall of the OR, and you can use in lifting. And make sure, even when we're lifting, you can see in all the slides that even when we're lifting, they're still putting caregivers, because although this thing can help us, but at the same time, we also want to leave it to machines to do. We as nurses, we as healthcare providers, we want to be there to ensure that the patient is safe. All right, lithotomy position now. If the patient's weight is less than 141 pounds, manual two-handed lifts of leg. So the patient's leg needs to be lifted by two people. Two hands, sorry, not two people. I don't see, well, it might be, but 141 pounds patient with two hands, that's still okay, but patient that I've seen all my life, 141, it's too small. All right. So going forward, one leg each on assistive technology. So what they're talking about is whatever we use in our facility to help style up the leg up, whatever it is we use. Make sure that one person is here, another person is there lifting the leg. Or if you want to use assistive technology, make sure assistive technology, one is here, one is there. Not the assistive technology using one to lift and then going back. It's not a good practice. The two legs should be lifted at the same time. All right, for weight that is 141 pounds and over, use assistive technology of minimum of 4 caregivers, 2 to lift each leg. So 2 persons on this leg, 2 persons on this leg. You're using assistive device to lift, but at the same time, 2 people are there to support and take the leg up. 2-3 is when they talk about lifting and holding legs, arm, and head off for preparing in a preoperative setting. These are the risk factors, just like the other ones. I will skip this. And then things that can happen also, we've talked about some of them. Most of them have the same risk of impact and potential factors that can occur. So essential task for this is to support the patient extremity or head to protect from injury. the task that's recommended for doing things like this is to minimize the risk of muscle fatigue and potential for musculoskeletal disorder. So we're not just doing this to help patients. I continue to say that every time, doing it to help ourselves. Be familiar with shaded and non-shaded area for guidance to lift and or hold the appropriate body part for a particular period of time. So depending on what your facility does, if it's shaded and you think this is area for you to touch or for you to guide, then just make sure you're following your protocols so you're not in trouble with yourself or anybody. Respect the time limit. So say, for example, the leg is supposed to be up for 20 minutes. Make sure you're having a timer, taking it up for 20 minutes. After 20 minutes, you're dropping it to rest, you're prepping and doing it again. Make sure we're not causing injury to the patient, even though we're trying to make sure we're safe. Injury to the patient too is something we don't want to cause. Use clinical judgment to assess the need for additional caregiver assistant or assisted device. So say, for example, you are doing a surgery and you already used bed extenders for this patient because this patient is obese. As soon as you see that the surgery has commenced, you want to start looking for extra help. Say you don't have enough people in the room to help move this patient. You want to start looking for extra help to help you in case you need the help. Not that when you now need the help, you're not doing it all by yourself, just 3 of you, when you need like 6 people to move the patient. Make sure you already have people that can come in and help you move this patient when the time comes. The fourth one is prolonged standing, which I believe is common to every one of us. One of the things that can happen is we stand in awkward posture or position. Always check yourself. I know sometimes it feels comfortable to stand in one awkward position and then you want to turn and change it again. No, always remind yourself, I need to stand erect. When you see someone standing in an awkward position, remind them gently too that you want to change your posture. These are the things that can help you and help ourselves. As you help yourself, you help people around you as well. Long duration of surgeries, when you have to stand long for surgical cases. When these kind of things happen, I know most facilities do this. If your facility does not, then this is something you want to also recommend, that people should come in for break at intervals, relieve the person, let the person go stretch, take a pee break, then come back. A person should not be standing 5-6 hours for surgery and nobody's coming to relieve the patient. It's not even to eat alone, but to stretch, to do some peeing and then come back. This helps the person. All right. Location or impacts of tax are back, the neck, knees, leg, feet. I know a lot of people that after standing for a long time, they tell you that their feet seems to be on fire. These are the things. And one of the other things I also recommend is when you know that your work requires a lot of walking, a lot of standing, make sure you're getting a good shoe. Shoes that are cushioned at the same time can create or give you good arch support. So when you're standing, you have this support with your shoes and you're not feeling too much of pain on your legs. All right. These are the recommendations for people that their work demands for them to stand for a long time, wear supportive and comfortable and closed-toes footwear. So just like I said, it must be supportive. Everybody cannot wear the same shoe. Well, a shoe that is supportive for me might not be supportive for you. It took me like 3 shoes before I found out a particular one that is supportive for me that I'm wearing. Another person finds it once, and if that is supportive for you, it's good to go. So just find someone that finds a shoe that supports you, and at the same time, a shoe that is acceptable in your policy. Don't wear a shoe. Don't say because someone told you now that you should wear a shoe that is supportive, and then you're wearing something that will not be tolerated in the OR. Always follow your protocol. Wear supportive stockings. So I used to say, if you're working for a long time, then I would advise you get some tech stockings. Make sure you have some compressions on your legs so that even though you're walking or standing for a longer period of time, you still have the support and you're not at risk for developing anything. Use fatigue reducing techniques. Example of them is alternate propping of one foot on foot stand, anti-fatigue mats. I know my workplace, there's a mat called anti-fatigue mats that surgeons that stand for a long time like to step on it, and then they continue their surgery. At the same time, you can alternate putting your leg on on the foot stand, and then you alternate another foot on the foot stand again. So do something like that just to help yourself and to help your posture. Be aware of neck flexion greater than 30-degree or rotation for more than 1 minute uninterrupted. So make sure that you're flexing your neck, make sure you're stretching your neck. At the same time, the kind of surgery, especially if you're scrubbing of the surgeon, we tend to bend like this for a while doing surgery. Make sure that at intervals, you're bringing it up, stretch, go back. Intervals, you're bringing it up, stretch, and go back. This for a long time can cause pain on the neck and the cervical region. You might not feel it when you do it once, twice, but doing it for over a long period of time can cause pain. Take breaks, rest breaks, or reposition when possible. Just like I said the other time, ensure you're giving breaks. It's not just you getting break. Excuse me. Also ensure that other workers working with you, nurses, doctors, are also getting breaks. Sometimes it might be very difficult for surgeons to get break, except they're being scrubbed out permanently or something urgent happens. But even at that, even if they can't get break permanently, sometimes I've seen situations where the surgeon might be fatigued, someone else steps in, the scrub nurse might be fatigued, someone else has to step in. We just have to look out for ourselves. That's the essence of what I'm saying. Look out for yourself, look out for others, so that everybody as a team is well. Use lightweight lead apron. So for example, you are doing a procedure that needs you to use x-rays, needs you to use laser too, for example. The things that we're wearing, make sure it's it's light-weighted. So if you're not putting on an apron that is weighing you down, you're feeling like you want to collapse. So make sure something you're wearing is protecting you. At the same time, it's not too heavy that you yourself cannot function. Consider a seat stand stool. So there are kind of stools that we use in surgery that I'm sure most of us know about, that we can sit on for a while. If the surgery can permit us to sit for a while we do the surgery, and stand when we need to stand. Maintain level of sterility. Even with this sitting and standing stool, let's also remember that sterility is important. So if this is going to tamper with sterility, it's not something we want to do. But if it's not going to tamper with our sterility, sit for a while, stand for a while when the need be. Retraction. I'm sure we can all agree with me. Our hands are so much risk. We have to hold retractors. We have to hold forceps. We have to help the surgeon in holding a bleeding vessel, things like that. So you can imagine doing that kind of surgery for a very long time. The impact we can have is on our hands, arms, shoulders, back. And the recommendation for this is to consider the use of self-retraining retractors for tax. I'm sure most hospitals are moving to this now. Be at optimal walking height or posture. So make sure that the height at which you're working with the bed is something that is optimum for you. Beds can go up, I believe, for most people. Bed can go up, bed can come down. So make sure that the bed is comfortable and it's a position that can help your posture. It's in a position that can help your posture. Did someone say something? Oh, all right. Hold the retractor as close to your body as possible and maintain good posture. So don't be stretching for you to hold it. Make sure you're holding it close to you as possible so that your posture is maintained. Avoid using hands on retractor to reduce risk of sharp injuries. So making sure we just use the retaining one. So they say we should avoid our hands on retractor so that we're not injuring ourselves, especially with sharps. Take rest break, just like the other ones, and use arm rest when devices is available. So if you have devices that can allow you to use arm rest, let's make sure we are using these arm rests. All right, I want to quickly move on to this so we can talk about how we can now help or solutions that we can do. Lifting or carrying supplies. If you need to carry things, I used to say that make sure that you consider the factor that affects lifting, e.g. the weight of the load, location where you're moving it from to where you're taking it to, the height of what you want to lift, and then we can use devices that can help us to lift things. If we don't have devices that can help us, get help for people to help you to carry that thing on a trolley, then you can push the trolley, not you by yourself putting it on your chest or putting it on your hand, and then you all by yourself trying to devices are available and where they are located in the practice setting you are, and insist on using them. If you find yourself forgetting to use them, create the habit of going back to get the device and then put the stuff you want to lift on them. If we continue to do this and remind ourselves, it's going to help us on the long run. You might be thinking at the moment that I just lift it quickly and take it to where I'm going. Think about the effect for a long time. Think about when you now have to leave the job. Think about your quality of life when you're retired. These are the things we start to think about now, so that we can help maintain a good health, and not that when we're now retired, we have to start nursing one problem or the other. Keep instrument tray weight at or below 25 pounds. This is AORA recommendation. If a instrument tray is above 25 pounds, do not leave the instrument tray. So every tray should have the weight of the tray on the tray. So once you see it, you know that this is 38 pounds. You know you're not lifting this by yourself. Can you just tell yourself, oh, it's just behind here, that just quickly enter the room? Don't do it. Look for something you can put the tray on, then you can now roll it into the place that it's being needed. The last one we'll talk about here is pushing, pulling, or moving equipment on wheels. So what are the task recommendations for this? Opt for pushing tasks over pulling tasks. So it's advisable to push than for you to start pulling things to yourself. Push at a comfortable middle height, about 3 feet for average height. So if you're a tall person, make sure that what you're pulling is comfortable enough and not you bending down in such a way that you're pushing or you're pulling. Make sure it's comfortable. It's a height that is comfortable for you, that you're not bending too much to get it to push. All right. If push force limit is exceeded, then reduce the weight of the load. So if you have to go 4 times, please go 4 times. Don't think I'll just do everything at once and I'm done with it. You might be able to get through with that, but just like I've been saying, think about it for a long time. What happens? Use 2 or more caregivers to complete tasks together. As much as possible, get someone to help you, get someone to do the job or the task with you, so you can share the weight of the load you're carrying, and then everybody is good. Use powered transport devices. I don't know if much facilities have this, but if your facility does and you need to push something, even if it has wheels, but it's very heavy, use all these powered devices to move them. Keep casters' wheels clean and well maintained to assist in moving equipment more easily. So all these things that we use in moving things, make sure it's always clean daily or as need be, so that when we need to grab them to move things, we can always grab them to move things. That's what it's just saying in essence. All right, now let's move to solutions that we can talk about. Some of the solution is to make sure that our workstation is well designed, especially, say, for example, our chairs, our desk, our computer height, the way it's placed, using of some light goggles, especially for people that type or use computer for their chatting, the kind of mouse we use, things like that can help us ensure that computer screen at eye level to reduce neck strain. We're not putting the computer or the table too low that the person that is sitting and is too high too tall cannot adjust the computer height or cannot adjust the chair height to help them. So these are the things we should consider. Patient handling equipment, we should utilize lifts, slings. I'm sure we all know what this is. We should utilize slide sheets, especially if we don't have the opportunity of having lifts or slings. We can use sheets, but there are ways by which we use them. For safe patient transfer, we should also implement adjustable height beds and gurneys. So the OR bed should be adjustable enough that we can put it in a position where it's going to help everybody that is supposed to move or is going to move. And at the same time, the patient's bed should be in a position that will not create strain when we're putting the patient on the bed. Tool design. Provide ergonomically designed tools such as scissors, such as syringes. So the way we're going now is making sure that the scissors, syringes are not being produced in a way that is going to create strain for the person holding them for a long period of time. Talk about retractors too. So they said in one of the slides that I just spoke about, that making sure the retractors is self-retaining. It can stay by itself, and then it can help us reduce strain on our hands, on our shoulders. And then we should also use lightweight, easy to handle instruments to minimize fatigue. Not that we use equipment that are so heavy and we have to hold them for a long time, or we have to carry them. Things like that are things we should consider when, I know to some extent, this particular one might not be something we can decide by ourselves, But if surgeon finds it that this is something that is creating strain to me, you want to bring it to the notice of your charge, of your director, whoever needs to know that this is creating strain for the surgeon, this is creating strain for me as a scrub nurse too, let them know. So if there's something they can do about it, they should be able to. All right. Best practices for reducing MSIs. I talked about training and education the other time. We're just going to reemphasize this, that over time, we have to continue to remind ourselves of what are the things we need to do, what are the things we're doing we need to change, things that are working that we can continue to work on. These are what training and education is all about, reminding ourselves of body mechanisms, mechanics, and also reminding others, not just you, your friends, your surgeon, your everybody working in the operating area, that you need to stand properly and you need to be in good position. Let me just also put here that we need to also sometimes get exercise, stretch, get some massage, just making sure we're in good shape to help ourselves and our patients. Encouraging reporting. Foster a culture where employees can report MSI, just like I said the other time, report to your charge nurse, report to your director, report to the surgeon in charge, whoever it is that you need to report to, without fear of repercussion. We should also remember to take regular breaks, that like I said the other time, and these help to promote, taking breaks to alleviate fatigue and prevent overuse injuries. Give breaks, take break. Don't just take break and don't give people break. Give break and also take breaks. How do we implement all these things that we've been talking about? One of the ways we can do this is to access the work practices. We should conduct an assessment on our workspace to make sure that we identify some risk factors that can make us have all these injuries. Once you find out there is a risk, and you find out how we can now properly channel, or people we need to channel to help reduce this risk. So say, for example, this is the chair we're using, is the table we're using. We can talk to our managers. How can we get a proper table? How can we get a proper chair, adjustable ones that can help the people using them? Involvement of staff. Engage healthcare workers in identifying ergonomic issues and proposing solutions. So I used to say every time, if they want to bring a change, the change should be with people that are using them, not just management alone that does not really or do not really use these things making the decision. They should be involving everybody in the OR, in the surgical area. Okay, these are the things we want to change. You have anything you want to include or anything you want us to subtract? These are the people using them, and they can always tell you that these are the things that is good for them. You can conduct a mini research and just find out the kind of chairs they want and why they want the kind of chairs we're talking about. Continuous improvement, regular updates, ergonomics practices based on feedback and new research. So say, for example, we've been using the table for a while or a mouse for a while, and now it's evidently based, or it's an evidence-based practice that using the kind of mouse helps reduce strain on hands. You want to find out about those kind of mouses, talk to your superior about them. If something that needs to be done, then it should be done. All right. There are I don't know why this came down here, but there are case studies and there are success stories. One of them was the one that happened in Virginia Medical Center. And in this hospital, what they did was that they implemented the ergonomic program for their staff, and that reduced patient handling injuries by 76% over 2 years. You know, I said it for when I first started this presentation, that if you are not in good health, and for example, you need to move a patient, your back is aching, you can drop the patient, and then the patient is injured. But what they did is they found out that when they implemented all these ergonomic good practices in their work, the rate at which staff drops patients reduced drastically. This is something that we want to look into. It's not just for ourselves alone, it's also has effect on patients, because if we continue to drop patients because we are not doing the things we need to do to help ourselves, the effect is also on us and at the same time on the institution. So these are the things we want to look at. Another one is Cleveland Clinic. They introduced ergonomic training for staff, and it resulted in 50% reduction of musculoskeletal injuries over 3 years. So they introduced all this training that we've been talking about since, how to stand properly, how they can bend, how they can carry patients without straining, what kind of weight or what's the limit to weight they can carry. And it's reduced MSIs by 50% over 3 years for them. So you can imagine doing this for a longer time, then you are going to see a better result as they continue to do it. So I want to conclude by saying that MSIs are very significant concerns in healthcare, and the impact of these on health workers, and the impact is on health workers and also affect patient care. At the same time, it is important that we provide effective ergonomic solution that can help reduce this injury. The call for action that I set for this is to encourage all healthcare professionals to advocate for ergonomic practices in their workplace to enhance safety and well-being. Don't just think about, okay, for example, I'm the manager, all I have to do is just sit and type or give instruction. Think about people that are working with you. Think about the quality of life you give them. Think about the quality of life you're giving your patient, and at the same time, think about the quality of life you're giving yourself. So this brings me to the end of my presentation. If we have any questions, please let me know. I put my references here if you want to go through them, and also thank you for listening.
Wow, wow, wow. Thank you very much, Oluwatoyin Akinlade, for this wonderful presentation. This is wonderful. It is mind-blowing. Thank you very much for your time.
She's still... I can't hear her again. I don't know what's going on.
That you giving to us. So we are going in for the question and answer. Hello, can you hear me?
Perfectly now. I can now.
Okay, okay. So we are going in for the question and answer time. Mr. Sunday, are you there to help read out some questions?
Good evening, Prof. My pleasure to anchor this part of the program. We actually have at the moment 4 questions that were posted at the.
You are welcome.
I'll just read them one after the other, allow you to respond. Is that okay?
Yeah, that works.
All right. The first one says, in a facility where there are no mechanical devices for lifting or transfer patients, what would you recommend?
All right, thank you so much. I said in one of the slides too that some of this, especially from where I'm coming from, some of these hospitals does not have all these fancy things to lift, but we can also use our sheet, the normal sheet. So just the first thing to do is to make sure you assess your patients before they come into surgery. Make sure you know their weight. And I said the other time, the recommendation is if the patient is weighs more than 35 pounds, you can convert that to kilogram if that is what you use. Then you know you will need 1, more people to lift the patient, 2, assistive devices. One of the ways you can do this is using the sheet, tucking the sheet on the bed, so that you know that once the surgery is done, this is the sheet you're using to transfer the patient. That is if the patient is on the bed. If the patient is moving from the bed to the operating room bed and the patient can do this themselves, you can support the patient, not just you, 2, 3 people, depending on the weight, support the patient on the bed. But as soon as the patient is done, you know the patient cannot move themselves. So that is why we can use the sheet, and make sure that you have enough hands, depending on the weight. Always, always anesthesia has the head, and then depending on the weight, 2, 3 people on the left and another 2, 3 people on the right to move the patient. Just remember, if the patient is more than 35 pounds, you need more hands in lifting. Then you, depending on your own assessment, you know how many people you're going to need in moving the patient. If the patient is just 37 pounds, aside from the anesthesia, you might need 1 on each side to move the patient. But say, for example, the patient is like 280 pounds, 300 pounds, then from your own clinical judgment, you can know that, okay, I need more than 2 people. I need like 4 or 5 people. That is why I said it's essential for you to make this assessment. And once you know that you're going to need this help, start sorting for the help as soon as the surgery begins. Not that when the surgery ends, you're not scouting for people to help you lift. You start searching for people, start asking for help, and you know the people coming in. And you also know exactly when for you to communicate to them, for them to come in to help you move the patient, if that answers the question.
All right. Thank you very much, Prof. The next question seems to be related with the one you just answered. You talked about getting support, getting staff to join. But this question is asking, in a manpower depleted setting, what do you recommend, or what would you recommend?
Can you say that again? In a manpower what?
Depleted, insufficient manpower.
Okay, the manpower depleted. Okay, yeah, it's I know, especially in developing countries, or it's something that we have to deal with all the time. That is why I said, even before surgery starts, ensure you know that this patient is going to need help. So the people do not have to necessarily be people that work in the OR alone. Although when they come in to help you, someone who works in the OR will be the one giving the instruction. This is what I want. So many times, and even in my facility, even though I work in the United States, so many times when you're on call and you're just 3, 4 people in the OR, and maybe it's an holiday, all I need to get is people that are environmental support workers that helps in cleaning. I get 2, 3 of them, and I tell them, this is what I need you to do. You're going to hold the leg like this, and you're going to hold the other leg like this. That's for another person. And then we're going to count. At the count of this is what we do. So you give them instruction. The bottom line is just getting people. It's not just getting OR workers alone. If you can't find surgery workers that can help you, find whoever you can find to come help you move the patient. Just that you give them instructions on what to do to facilitate a proper movement of the patient.
Yeah, thank you very much. I think this explanation will be very useful. Get prepared, and at the end of the day, you can get help from anywhere. Just make sure they are supervised and they are tutored on what. Beautiful. There is another question here which also borders on resources. It says, in case of low resource material, how should the OR team lift patients over 100 kg yet avoid musculoskeletal injury?
It boils down to assessment. Yeah, the first thing is always assessment. Before the patient comes into the OR, that is why it is important to visit your patient before they come into the OR. Not just because you want to know them, also because you want to make some clinical judgment on things you might need, even before they come into the OR. Say, for example, you're saying the patient is 100 kilograms and higher. That means you might know that, okay, and then maybe the patient has some other comorbid conditions. You know things that you might need. You may not later use them in surgery, but visiting will help you know, okay, this patient is going to need support with lifting. This patient is going to need extra anything. What I'm just saying is making sure you assess the patient first to know exactly the needs of this patient, and then you start to prepare. It does not necessarily have to be OR staff alone. If you don't have the resources to have OR staff to help you at that time, get the resources you can get, give them direction of what they can do, and we can all help move the patient without injury to the patient and injury to ourselves.
Wow, thank you very much. This might just be the last of the questions we have here. Okay. It's a bit, I'm not very sure, but I'll leave it to you. It says, in the OR setting, who is to bring in patients into the theater and out of the theater? That's like a transfer of patients in and out of the theater.
I'm telling you, most institutions have different practices, but most that I've seen is the circulating nurse that brings the patient into the OR. The scrub nurse is already prepared. The circulating nurse brings the patient in. There's another nurse that brings the patient to the waiting area, and then they do the transfer from there, and then the circulating nurse now is in charge, or whoever the facility. Every facility has protocols. Every facility has job descriptions. So just make sure you know exactly what your facility uses or does, and that is what you should follow. But for me, I used to say, if it's not beyond my scope of practice, I don't have problem with moving patients. Where I work, I've seen surgeons move patients so many times because the circulating nurse is busy doing something, the scrub is busy doing something. The surgeon does not mind. It will bring the patients to the room and then introduces the patients to everybody. That is because the circulating nurse already met the patient in the waiting area. So it shouldn't be a thing for debate. Just know what is applicable in your facility, follow it. But most of the places that I've seen is the circulating nurse that brings in the patient.
Yes, thank you very, very much. I think just summarize what came. So,
can I say something? Hello. Yeah, I have a question. I have a question. Can I ask? Hello.
Hello, Prof. I think there's someone that wants to ask a question. Okay, go ahead and ask your question.
Yeah, it's a concern about because although I came late, concerned about the presentation because I came late. But on the area that I met on the presentations, concerned about the patients, how to prepare the patients in the theater. So like if like we are giving like a spinal to the patient. Hello? You get me?
I can hear you.
Yeah. So if like we are giving spinal to the patient, but like this patient is like unconscious.
Okay.
So which position normally are we to put this patient?
Okay. I'm not an anesthesiologist, but I will talk as a nurse and as things that I've seen. First, anesthesiologists would assess at the same time you as a nurse would assess, and you know the side that best fit the patient, the best to put the patient. I'm sure we would all agree that prone will not be a good position. That's one. And the patient cannot sit or stand or sit majorly because they are comatose. But at the same time, I believe what we can use best is either use a left lateral or use a right lateral, depending on the anesthesia you're working with. The only thing I would say to that is if we're doing that, most of the anesthesiologists that I've seen would like to give, especially if the patient is unconscious, would like to give a spinal on the patient's bed before they transfer to the OR bed. Most of them that I've seen would like to give the spinal on the patient bed. This is because, one, the bed that we bring the patients with has rails on the side. So if they're standing on one side, the other side the rails can be up and serves as a protection to some extent for the patient, so the patient does not fall off, even though there's someone also standing on that side. And then the anesthesia provider can be on the other side, do the spinal, and someone else is also standing beside the anesthesia to make sure that the patient is safe. Do I answer that question? Does that make sense?
You are right on the point.
Thank you.
Thank you. I think that might just be it because we are time bound and we are about exiting our time frame. At this point, I will call on Mrs. Helen to please continue with the next item, which is the closing remark. Thank you.
Thank you very much.
So thank you very much for your presentation.
Thank you very much.
You really deliver everything well. So I hope everybody will take a note of it. Thank you very much.
Thank you very much. Mr. Oluwatoyin Akinlade, we appreciate you very much for giving us your time for this timely presentation. As a Workplace Health and Safety Committee, we conducted a need assessment and using health caregivers telling us what they are going through in their facilities. And we discovered that many of the injuries that were mentioned, the one that's caused the highest percentage is this musculoskeletal. And that is why we have given it out so that it can be addressed. And it is important to know that workplace health and safety is very essential, just like you have mentioned. So as a committee, we are going to look into other aspects of workplace safety, which include psychological safety and anti-bullying initiatives, workplace violence prevention, training and continuous support, monitoring and evaluation, just like you have actually made us to understand. And we hope we are going to, while we go along with this, using some hospital as samples, and we train, even physical training, and we continue to monitor and evaluate, perhaps we will get somewhere. So we really appreciate you so much. And I appreciate everybody on this platform, those who have come from one country or the other. We really appreciate you for your time and staying tuned till this present time. The Operating Room Global is an organization that unites all operating room users under one umbrella worldwide. And we are committed to dedication, driving progress and innovation in healthcare. And we are doing this through knowledge, collaboration, advocacy, research, education, and global impact. So if there's anybody here that is not yet a member and is OR user, please, we encourage you to be part of this global organization that is wanting to deliver surgery in a safe way, and by taking care of the welfare and health of members. So thank you very much, everybody. I appreciate. And I must appreciate also the CEO of the Operating Room Global, Mrs. Adebusola Owokole. She is the initiator of this Operating Room Global. Kudos for her, and we really appreciate her. So I want to thank you very much. Mrs. Oluwatoyin Akinlade, thank you for coming. Everybody on the platform, thank you for coming. And we hope that what you have learned, you will take it to your facility so that you can practice it. And next time when we call you again for another presentation, you will oblige. Thank you very much. Anything from any committee members? Does any committee member want to add anything? If not, we are calling it a day. So thank you very much.
Yeah, thank you, the host, and also the presenter. Thank you so much.
Thank
You
you
really
so much.
deliver everything. You really deliver everything very well. So we hope another presentation will be more amazing also like this. So thank you.
We appreciate you so much. We enjoy the lecture. God bless you.
Thank you so much.
Thank you so much, Ms. Oluwatoyin. God bless you. We appreciate your presentation. Thanks for coming.
Thank you for having me.
Thank you.